Hi everyone, so I'm Akash, and I'm going to be presenting on dementia and delirium today. So let's get started. This is me, looking very chipper when I haven't just finished a night shift. So I'm an ST4 medical registrar, and have a couple of various qualifications there. And we're going to start off by talking about dementia, and then we're going to move on to delirium. So a little bit about dementia. Why is it important? Dementia is important because it's so common. I mean, I can't imagine how much you guys must see out there because I see it a crazy amount. Literally over the last 3 nights that I've done, perhaps 1 in 3 of my referrals were somebody with delirium or dementia, and so it's something that you can't take lightly and something that you really do need to know about. As always, I welcome lots and lots of questions during the talk, so just pop them all down, and at the end, I'll answer all of them. So, as I said, it's very common. About 7% of patients above the age of 65 have dementia. And if you're looking at 80 plus, that's 1 in 6 of them. They tend to be frequent attenders in hospital. And it's not surprising that that's the case because it's really easy to miss a diagnosis in somebody, particularly if they're impaired in some way where they don't remember the symptoms that they had, they don't remember the illnesses that they have, or they don't respond to them as another person without that memory impairment would. And even when they do come into hospital, they do present to you, you'll find that actually assessing them is very difficult. You can ask only very limited amounts of history or examinations depending on how advanced their delirium and dementia is. And so you're asked to see Mr. Andrews. Mr. Andrews is an 86-year-old male. His family has reported that he gets a bit muddled from time to time. So you're querying, is this cognitive impairment? Is this dementia? Well, what is this? How do I assess this? And how do I know? Because what it's going to do is whether I'm a therapist, whether I'm an A&P, wherever I am on the journey that sees this patient, actually being able to understand how bad his cognitive impairment is going to make a difference about what treatment and how I support him. And so you'll get a little bit of further history. You'll find that it's been many years that things haven't been quite right. Over 5 years, he's been unable to manage his finances, cook, keeping up with conversations has become difficult. He finds that he frequently forgets dates and times, and he seems quite upset by this. You also find that he used to be able to manage his own accountancy business beforehand. And that's really important because the fact he can't manage his own finances and used to have an accountancy business says that actually things are really not good. The diagnosis of cognitive impairment is all about function, all about what they find difficult to do. It's not just, oh, I have a little bit of a memory lapse. We all get that from time to time. We all have little blank spells, but it's about it actually impacting on your life and making it such that you can't carry out the activities that you need to be able to function. If you find it difficult, and I'll be honest, I think pretty much everyone does, I personally do, to remember what kind of questions to ask, to work out, is this quite right? Well, there are 2 ways you could go about this. Some people like to go through the day. So they say, well, when you wake up in the morning, what do you do in the morning? And go through each activity of daily living to work out what they struggle with, what they need help with, and how that's changed. Another thing that you can use is the IQ code. That's the informant questionnaire on cognitive decline in the elderly. It's a really easy way because all it tells you is, and this is something that you ask the family or any other loved ones of the patient, you basically just go through these questions saying, look, how have things changed from 5 or 10 years ago? Are they still able to remember birthdays and addresses? What about recent events? Can they recall them? Can they recall what's happening in a conversation or a conversation that's only happened 5 or 10 minutes ago? Do they remember their address and their telephone? What day and month it is where things are kept? Are they finding it difficult to learn new things or use the machines they used to do or make decisions, particularly in handling money? You can see that it's actually quite a global thing that you're addressing. It's not just, are they forgetting things? It's also about, so amnesia. It's all about also about apraxia. Are they forgetting how to do things? It's with that dementia, it is not just a diagnosis of forgetting one or two things. It affects you globally, it affects all your activities, and that's really important to know, because it's not just that they find it difficult to remember something. They'll find it difficult to remember the word for something. They'll find it difficult to make tea, and this can really impact on their ability to function. And as things get more advanced, they may forget to do things that are inherently needed to keep them safe. For example, lock the door, switch off the gas. And those are really key questions to ask to work out how safe your patient with dementia is. In the initial stage, it's not always dementia. And this is why geriatricians and memory clinics are so helpful, because you've got to think about what else could it be? Is there something that's reversible? So these are the kinds of things that we look for. Delirium. So in delirium, it's normally only a few weeks at max, can be a few days. With dementia, it's typically a few years. We'll do a set of blood tests to look for electrolyte abnormalities such as sodium or calcium that can impair your cognition. Mood. So you really can't diagnose somebody who's particularly anxious or particularly depressed. The key difference will be, rather than them saying in dementia that they will try and they will struggle to do an activity, with depression often they say that they can't do it or won't do it because they lack the energy to be able to do that task, rather than the memory or apraxia to be able to do said task. Having visual impairment or hearing loss can affect your ability to relate to the world around you. And so rather than them forgetting parts of the conversation, perhaps they may be never heard of in the first place. Nutrition, so particularly B12 and folate deficiency. So another 2 sets of blood tests to add on, as well as thyroid function tests. Infection, so if you have a kind of chronic grumbling infection or illness, that can affect your entire body, not just so as a result you can not be as cognitively good as you normally would be. And finally, anemia is something to look out for, because that can give you tiredness, inability to concentrate, and again that can simulate what you would think would be dementia, but really a pseudo-dementia. The types of dementia you're looking for are these 4 types. And the most common of all of them is Alzheimer's dementia. So Alzheimer's dementia is characterized by the 5 A's. Amnesia, the inability to remember recent things. Apraxia, so that's the inability to do things that they would normally be able to quite easily do. For example, make a cup of tea. It's not because they don't know how to make a cup of tea, it's that they just don't know how to get everything together, and what goes in what, where does it go next, what's the next step, that kind of function part of it. Aphasia, that inability to find the right words. Agnosia, the inability to recognize things. So you'll show them a pen and they'll be like, oh, I don't know what that is. Well, to be fair, that's more anomia. Agnosia would be more, they can't recognize faces. Anomia would be if you showed them a pen, they can't remember the name for it. So the lack of knowing a noun. The next most common is vascular. Vascular Alzheimer's disease is very, very related. In fact, a lot of vascular risk factors or head injury or alcohol puts you at risk of Alzheimer's disease as well. And so more and more we're moving forward from saying that these are 2 different entities to say that most patients have a mixed or overlapping type. Characteristically of pure vascular dementia, though, is kind of a stepwise decline. And so they'll be good and they'll have kind of small little infarcts in their brain to the point where they will then step down, being much, much less able to function. But those could be such little steps that actually it would be more akin to Alzheimer's disease. In reality, though, it doesn't tend to make so much difference in terms of what you do. The only thing to note that is with vascular dementia, there may be particularly more issues with kind of falls because they've got neurology. So they may have unsteadiness or weakness. With Lewy body dementia, this can be quite easy to confuse with delirium because of this kind of fluctuation. So essentially, you get this fluctuating cognition. So sometimes they can be really bad, and sometimes they're a lot better. But what it does tend to have is rigidity. So they've got kind of Parkinsonian features, where when they walk, it's a really, really shuffling gait, and they're prone to risk of falls. And they can also get visual hallucinations, which can be really disturbing, really horrible for them, because then they might see that visual hallucination, try and run after it, be unable to walk, and therefore fall. And it just makes it a really horrible cycle. And finally, there's frontotemporal dementia. So these kinds of regions, particularly our frontal lobe, is in charge of our decision making. It's what kind of guides us. It's the front of our head. And so when you lose this, you lose the ability to do things that you know you shouldn't. So often these patients will start to urinate in random places or start to strip down. And that can be really, really disturbing for them. Well, less so for them, but more their the family around them and their partners. And so that's something else to consider. The way that we diagnose dementia is through a really thorough assessment. A lot of patients will be labelled, "Oh, you've got some memory impairment," and suddenly on their record it will say dementia. But that dementia is never formally diagnosed, and it can be really harmful to erroneously make a diagnosis of dementia. Often patients with dementia automatically assume that they don't have capacity, that they may have treatment limitations, saying that, well, no, they've got dementia, so they're not appropriate for CPR. And so for those reasons, dementia can be quite debilitating. Also, from an emotional point of view, if you've got a family member who's been diagnosed with dementia, you can feel quite upset about that. In reality, that's not how we should treat patients with dementia. Ultimately, dementia is a massive broad spectrum, from patients who are very much able to cognitively make decisions about their healthcare to those who are not. And so everybody should be assumed that they do have cognition until otherwise proven. In a memory clinic, having done many of these, what you'll do is you'll essentially focus on function, ask all those questions to work out what has changed in the last 5 to 10 years, and what have you got in front of you. Aim is to focus on function. What is that they cannot do? In addition to that, you will do an MMSC or other cognitive assessments, but all of those should be guided by who your patient is. It's very different to do a memory assessment of somebody who's never spoken English, who's never been to school, versus somebody who used to be a university professor. And so you really need to tailor your assessments to who the person was, and tailor your expectations of what they should be able to do. A person who is a university professor, if they get 29 or 28 on an MMSC, I'm like, well, that's not quite right. Versus somebody who doesn't know how to speak English and therefore can't read half of the assessment. This really should not be done as an inpatient, because for many reasons, particularly delirium, you just cannot function if you're sick at your optimal state. And therefore, it's very easy to mislabel somebody with a diagnosis of dementia. The blood test will focus on looking for all of those things that I mentioned, as well as a CT scan, because you always need to make sure that you are not missing something which actually could be reversed. The management, there's lots of different things. There is pharmacological management, but honestly, the amount of drugs that we've got is limited, and the amount they benefit is quite limited. And so it's really a focus on these non-pharmacological methods, and that makes the world of difference. Engaging with these patients, dance or music, or sensory therapy, helping them exercise. I often see our physiotherapy team doing kind of group classes for these patients on the ward. All of these things make so much more difference, and they're so much more important than anything I can do as a doctor. Animal-assisted therapy is also really, really helpful. The other thing to think about is advanced care planning. So ultimately, they will reach a point where their dementia will creep up on them to the point where their life will be limited by their dementia. That's quite common. It is better to make these decisions about what they would want when that happens, when they're able to answer those questions, when they're able to communicate and discuss those things. It's very easy to say, oh, I don't want to talk about those things because I want to focus on the person that I have in front of me who's happy. And often their partners will describe this, but actually it's really important to get those views down. Now, if they don't want to talk about that or they want to delay it, that's okay, that's their choice. But you need to be able to just open up that situation of what will happen when this happens. Because otherwise, what will happen frequently is they will come into hospital again and again and again, getting antibiotics after antibiotics after antibiotics, and getting quite distressed in hospital. And perhaps that's not what they would have wanted. If that is what they would have wanted, that's a different situation. But there is a very good chance that that's not what they want. And so we need to take their views and wishes into account. And so that's my quick rough summary of dementia. A little bit about how to ask the right questions, a little bit about how to consider other causes, the types of dementia and how they might present and how that impacts you as a clinician. How we go about diagnosing this, and how management is so focused on having that multidisciplinary team, making sure that together we help the patient. Now we'll move on to delirium. And again, we'll take the same approach. So delirium is important for exactly the same reasons as dementia is. It's so incredibly common, even more common than dementia. If you work in hospital, you'll find that 20 to 30% of patients on the medical ward will have delirium. And in post-surgical patients, it's about 10 to 50%. So wherever you're working, unless you're in pediatrics, you're really going to be encountering it. It is frequently associated with life-threatening pathologies, and it's so difficult. You get very limited history and examination. So how are we going to approach our history and examination in a patient with delirium? Well, we're going to do two things. One, we're going to work out what the patient can and can't answer. There is no point just keep asking, okay, what did you come in? What's the symptom? Why have you called an ambulance? Why have you come to hospital? What are you doing in hospital? If they can't answer that, they can't answer that. But what you can do is ask them about their present moment. They are going to know if something hurts right now, if they have any symptoms right now. And often it's really helpful to observe these patients. So get them doing what they would normally do and see what they're limited by. Are they moving all of their forelimbs? No. Oh, well, maybe one of them is painful. Are they passing urine? No. Maybe they're in retention. When they pass urine, are they wincing? Those are the things that are going to give you a bit more of a clue than asking them at length. The other thing that's really helpful is getting a collateral history. I can't express how useful this is wherever you are. Me at the front door of when I'm on the acute medical take, I rely on a collateral so much. And so when a paramedic comes and they present, this is what the patient is normally like, and this is what has changed, that's really helpful because I know what I'm looking for when that patient is well. And often it's so difficult to get that baseline when you are when you're unable to in the middle of the night, for example. And so when somebody presents that to me, it really tells me, okay, well, this patient is very off their baseline. Oh, this patient's mildly off their baseline. It gives me an idea of what I'm working towards and also what the rest of the multidisciplinary team are working towards. Are we aiming to get this patient up and about and walking and chatting? Or are we aiming to basically get this patient to transfer with assistance of one or two? Let's say you are presented with a patient with delirium. So Mr. Andrews is an 86-year-old patient, the same 86-year-old patient who we and made a diagnosis of Alzheimer's dementia earlier. And he's got a past medical history of dementia, hypertension, type 2 diabetes, and he's confused. He's got AMTS of 3 out of 10. He's tachycardic, he's a bit pyrexial. His stats are okay though. His ECG shows a sign of tachycardia and his blood sugar is normal. Essentially, what we're looking for is whether this patient has delirium. So delirium is essentially acute confusion. And it predominantly goes into 3 different types. And so you've got the hypoactive type, where they've got lethargy, they've got inattention, they're more sleepy. The hyperactive type. So classically, in hospital, these are known as well, not classically, but they're often your patients that you find really difficult to manage because they're trying to reach and trying to get out of bed. They are bothering you all the time. The hyperactive patients are the ones that are easy to miss. You might label them accidentally as a good patient because they never bother you, but actually they never bother you because they're constantly delirious. They're lethargic, sleepy, drowsy, inattentive, and so they're never attending to their own needs. They can also have a mixed type where they have a fluctuation between hypoactive, hyperactive, or both even at the same time. The risk factors for delirium predominantly are dementia or previous delirium. Being older is also a risk factor, but really this focuses on frailty. It's that functional status that's more important, and that inactivity that's more important than simply how old they are. And finally, comorbidities, particularly alcoholism, will massively increase your risk of having delirium. The causes of delirium, so lots of people like the acronym PINCH ME. And so there's a really simple way to assess your patient wherever you meet them. Are they in any pain? Do they have any signs of infection? So for pain, assessing them and examining all of their limbs and making sure everything is moving right. Infection, have they had any cough, any shortness of breath? Do they have any suprapubic pain? Are they having any burning or stinging when passing urine? One thing to note here, foul-smelling urine does not confirm a diagnosis of UTI. It's very easy to say, oh, they've got foul-smelling urine, they've got a UTI, but actually, there's a pretty much about a 50% chance they do or they don't. It's I think about 56%, which means you could equally diagnose a UTI by flipping a coin. Lots of things make your urine foul-smelling, and UTIs are frequently not the cause. Nutrition, so whether they've been eating poorly, constipation is a very common cause. Have they recently opened their bowels? Actually, it might be a situation where the best thing that one can do for a patient is just give them laxatives, and that might actually fix their delirium. Hydration, have they been eating and drinking well? Medications, have they started any new medications? So particularly your anticholinergics can impair your cognition. Codeine, sedatives, opiates, they can all impact your cognition. And then the environment, have they moved to somewhere new? Is it particularly dark? Are there no windows? Have they not got their hearing aids or visual aids? All of these things can impact or worsen delirium. Here is a more kind of medical way of looking at it to those who work in an environment where actually having more medical viewpoint may be more useful. So drugs, dehydration, detox, electrolytes, lack of sleep, infection, infarction, so we're talking about MI. Renal failure, infarction also means stroke as well. Renal failure, fecal impaction, UCIs, and metabolic things like glucose, thyroid function tests, so hyper or hypothyroidism, malignancy. In our assessment, we're going to focus on that history and examination, as I said, looking at what the current situation is if we can't get that history about any events that have occurred before this moment. Our AMTS is very useful because it will really easily stratify how cognitively impaired your patient is. And finally, the most important is getting that collateral. For any patient who is confused, where you can't get a history from them, you must get a collateral. Because otherwise, how are you going to be able to address what the actual issues are? Our AMTS is basically an abbreviated mental test score. What it does is it looks at 10 different things and looks at how well they succeed on these things. I would recommend the easiest thing to do is just Google this. MD Calc has a very good app for this, calculator for this, or you can literally just reel them off and test your patient, because it's very powerful to say, this is a patient with an AMTS of 9. This is a patient with an AMTS of 3. It immediately tells you what the patient in front of you is like. There are some things that you may need to modify. So, for example, the name of the Queen or the Prime Minister, or the date of World War II, particularly for patients who have a different ethnicity or were not born in the UK. They may not know these things, and therefore asking them these things to address whether they have whether they remember these things is pointless. AT is far more helpful in diagnosing delirium. So the AMTS will tell you if they've got impaired cognition. That impaired cognition could be because they've got delirium or because they've got dementia. So the utility of an AMTS is being able to compare. If you know what their AMTS is at home, then you know what their AMT when they're well, and you compare that to the AMTS in front of you, you immediately know how much worse their cognition is, in less of a subjective and more of an objective way. With a 4AT, it's focused on scoring whether delirium is likely or unlikely. And so this is focusing on the fact that delirium is predominantly more characterized by alertness. That memory impairment is definitely there, and that inattentiveness. So your demented patient will usually try and do an activity. Your delirious patient will either be too tired to do that activity, or not be able to concentrate to do that activity, or have this kind of fluctuating ability that you'll either see, or when you ask, the family will tell you. Your initial investigations are basically doing a screen for all of those causes that we just considered. Looking at their glucose, looking at their bloods, their hematinics, such as their B12 folate, their thyroid, their electrolytes, their urine MCNS. You must use an urine MCNS because, again, you cannot diagnose a UTI or a urine dip, because if you're above 65, about 50 to 60% of patients will have a permanently positive urine dip. And so it's just not helpful. They basically have asymptomatic bacteriuria. So you have to send that sample off, or empirically treat them in the situation where they've got symptoms of a UTI. And once again, not foul-smelling urine, but burning, stinging when they pass urine, discomfort when they pass urine, they've gone into urinary retention, or they've got suprapubic pain. And a chest X-ray and a CT head are also very helpful in these patients, particularly a CT head in those who've fallen. Your treatment algorithm is, first of all, identifying the underlying cause. Delirium is not the diagnosis. Delirium is the symptom of an underlying diagnosis, be it medical, be it environmental, or something else. You need to support and orientate these patients. One of the most helpful things that you can do for these patients, whether they're at home, whether they're in the back of your ambulance, or whether they're in hospital, is constantly tell them what's happening. Because imagine if you couldn't remember what was happening. Every moment would feel like agony for you. You'd be like, where am I? What's happening? What is this? Why am I stuck in this car? Why am I in this unfamiliar environment? It is so anxiety provoking and scary. Can you imagine feeling like that all the time? And so one of the things that will really help delirium, will help those patients who are agitated, is just telling them where they are. One of the powerful things you can do is surround them with photos of people that they know, a calendar which tells them what date it is, and a piece of paper or something that just tells them where they are and what's happening, why they're there. It's just instantaneously reassuring and really helpful for them. Medications are really reserved as a kind of last resort. They often can make things worse because they impact they work by essentially sedating you often and impacting your cognition as a result. So they really should be reserved for situations where you need to prevent the patient being either harming themselves or others. So, for example, the patient that is hitting other patients or pulling on everything, for example, their catheter, and non-medical therapy such as light restraints or other things haven't worked. The last thing is to explain things to the patient, but also explaining things to the family. Because imagine if your loved one suddenly became delirious, you would think, oh my gosh, is this what's going to happen to them? Is this how they're going to be for the rest of their lives? This is really scary. I can't cope with this. I can't manage this. I feel really, really worried. Because of how catastrophic it looks, people can think, oh my gosh, they are so horrifically unwell. Often when they get discharged, people are like, oh my gosh, how could you discharge them like this? You haven't fixed them. It's important to explain things at length. When we're looking for the underlying cause, we're looking for those drugs that we can stop or reduce. There's electrolytes that we can identify and escalate such that we can get the right treatment for them. Constipation, the laxatives, I really like Movicol, but doctors say it works too. So Movicol or phosphate enemas are very, very good because they really disimpact pretty much anyone if you give enough sachets. UTI, as I keep saying, it's often not a UTI. And the reason that I keep saying this is because lots of patients will be labeled UTI, get treatment for UTI, and you'll completely miss the actual thing that's causing it. And also, it doesn't have to just be one cause. It can be multiple. So just because you do find one doesn't mean it's not another as well. And then nutrition and environment, things that I mentioned, like finding their glasses and giving them their hearing aids. The medications that you can use are haloperidol or lorazepam. Typically in most hospitals or most guidelines, haloperidol is the first that's to be recommended. But if you are giving haloperidol, you have to be very careful of two things. One, QT, so haloperidol will prolong your QT, and so that can be risky for patients. And the next thing would be it can worsen Parkinson's or Lewy body dementia. So if they're rigid, haloperidol will make them more rigid. The thing to explain to the family are these three things. First, elderly patients can get muddled when their brain is under stress. Anything can make a brain stressed, from illness or other things. Just like when you or I are stressed and our heart races, in an elderly person, it's the organ that's impacted rather than the heart is the brain. This can take some time to get better, but usually it does get a bit better. And patients often return back to their complete normal selves. But this is best done in their own home environment. If we completely rule out any medical causes for their delirium, then actually it's often the fact they're not in their own environment, and being in their own environment, surrounded by their loved ones, surrounded by the things that they know and understand, can make delirium a lot better. Yes, it's difficult to have your loved one at home when they're so confused, but it is much better for them. And keeping them in hospital will not improve that delirium frequently. Finally, it will likely reoccur because delirium is a product of having a frail brain, which means whenever another stressful episode occurs, is much more likely to occur. All patients who present with delirium should be referred through to memory clinic because they will need further assessment because many patients will present with delirium as their first presentation of dementia. And so it's so common that it's important that we send them to a memory clinic, not just because they will diagnose the dementia, but also because they will do that systematic analysis of every single thing to basically improve the function as much as possible. And looking for all of those chronic illnesses, all those chronic pathologies that will cause impairment and essentially chronic illness, they can fix those things and make patients so much better. I cannot stress how amazing memory clinics are. And so, to summarize the delirium part of this session, you're looking for hypoactive or hyperactive delirium. It's very easy to miss hypoactive delirium. So make sure you speak to your patient, find out, do the 4AT, or find out if they know where they are and what's happening. Pinch Me is a very helpful, quick acronym to look for the causes of delirium and quickly address them and reverse them. And AMTS is powerful to know where your patient is compared to where they were and where they will be in the future. Blood electrolytes, chest X-ray, and CT head will find most of the common causes of reversible delirium. You must find this cause and treat it, and try to avoid medications to sedate the patient, because this will often make it worse. Finally, a shameless plug. So Mind the Bleep is my website. I have plenty of articles. I really should have updated this from diarrhea to dementia, so apologies for that. But I have articles on dementia, delirium, as well as diarrhea. You can also tweet out to me at Mind the Bleep. So if you are tweeting out to CPD&E, please do copy me in, because I love to see your comments and messages. And then finally, we have a massive section with a good 15 minutes for questions. So please ask everything that you want to ask, because I'm really keen to answer all of your questions.